So, local antibiotic delivery beyond cement. When we think about antibiotics in the presence of orthopedic infection, there are 5 Ds. Diagnosis, the organism; dose, an appropriate level; duration, long versus short courses; duality, we never want to go monotherapy unless we really have to, so we want dual therapy antibiotics; and then delivery, systemic versus local. And why local antibiotics? Well, with systemic antibiotic therapy, you have an unknown and often low concentration of antibiotics at the site of the infection. It's a purely vascular field. You also have possible systemic effects from the antibiotics. As an example here, where the patient on doxycycline had a significant reaction to sun exposure. With local antibiotics, however, you can get a very high local concentration where you need it, and you avoid all systemic effects. For almost all history of modern orthopedics, it's been bone cement that has carried the antibiotics for us. And we did this back to the late 60s and the first publication in 1970 by Buchholz and Engelbrecht, showing that gentamicin will leach out of cement and will be effective as part of your therapy. And it can be used for both prophylaxis at a primary setting and therapeutically when you're treating infection. The problem is that bone cement, PMMA, is not porous. You need liquid to go into the porosity if it's there and absorb the antibiotics to pull it out. So you then have to manufacture deliberately porous antibiotics to treat the infection, or to allow antibiotics to treat the infection. And Aaron's just given a very elegant talk about mobile spacers. If I'm doing a major reconstruction with a 16, 18 centimeter defect, I tend to use static spacers, and I use them in a way that allows the maximum amount of antibiotics to reach the field. So we have a central core of metal rods covered by a quick setting cement, over which we then put a skin of pre-mixed antibiotic loaded cement so that all the elution comes from the thin surface area. And then we stipple with a McDonald as a setting to again increase surface area and allow the maximum absorption of antibiotics where we need it. But there's a problem. PMMA will elute for a very short period and will only elute from the surface. Beyond that, after 2 or 3 weeks, it's simply a foreign material. And foreign material, if you haven't cleared the infection, leads to bacterial resistance. As in this case, where gentamicin beads have been used to treat osteomyelitis, but the beads themselves have become the sequestrum, and we've had to take them out years later to cure the infection. So where do we go beyond cement for antibiotic delivery? And there are several options: injectables, collagen fleeces, bone graft, calcium mixes, polymers, and then the novel antimicrobials. Again, back to my colleague Charles Lautenbach, when he taught me about suction irrigation, where we put tubes into the site of the debrided infection. We can use the antibiotic of choice, we can change as needed. It's very cheap, it's very easy to use initially, but hard work to keep using it. And it means the patients are pretty much bedbound until those tubes come out. So although I did this for 2 years early on in my career, I no longer use direct injectable antibiotics. Collagen fleeces. For many years, these were the only alternative to PMMA cement. Primarily used for surgical prophylaxis, and it gives you gentamicin coverage only. I did use it for quite some time in my distal femoral replacements for prophylaxis as a biological wrap around exposed non-articulating metalwork, and I was quite pleased with that. Impregnated bone graft. My colleague Heinz Winkler from Vienna is really the doyen of impregnated antibiotic bone graft, and he's done some very, very good work on it. It has a large series, and I'm not the man to talk about this, but I commend the Society to invite Heinz Winkler as a lecturer sometime. He will give you an excellent talk on the use of bone graft to deliver antibiotics. Most of my experience recently has been with calcium sulfate, Stimulan. It allows me to mix on table at very high concentration exactly the antibiotics I need. It gives me an extended delivery program of elution, much longer than I get with bone cement, and it's truly bioabsorbable. I'll just give you one case example. Patient sent to me having had two-stage revisions elsewhere. He's had a free latissimus dorsi flap to cover the defect, and he has a loose infected implant. So in this case, it's a 2-stage for me using an apple core spacer with lots of Stimulan. If you can see the beads that are around the cement spacer, but also inside the canals. And they fully bioabsorb over an 8 to 10 week period. And then we can go back into the second stage using a silver-coated implant, but again, large quantities of Stimulan, so I've got a high antibiotic yield exactly where I need it. We can also use calcium phosphates, hydroxyapatite. It's fully bioabsorbable, and you can add in molecules and proteins attached to them, such as antibiotics. And based on the size and structure of the nano-hydroxyapatite, you can get elution antibiotics over 3 months up to 3 years, so a much longer profile. We've got synthetic polymers, polylactic acid, for example, which again you can bind antibiotics to and will give you sustained release over much longer periods. Polymers can be used as gels if you want a quick release of antibiotics, or they can be coated in biocomposite materials such as alginate, pectin and fibroin. And again, these will give you a slow degradation and release of antibiotics over months and years if needed. We already mentioned acetic acid and honey and iodine and other novel antimicrobials. But there's also the possibility of using glass. Glass of itself is antibacterial, but you can add in antibiotics and it'll elute slowly. You can add in silver to give a higher yield against bacteria. And then you've got metals themselves. We should all know about silver coatings now, but titanium itself can be produced as nanotubules with the antibiotics loaded into them. Gallium is an iron analog which will turn off bacterial iron-dependent pathways and has a very broad antimicrobial activity. So, I'm sure some of you think I'm a bit of a cowboy surgeon talking about vinegar and honey and gallium and all these crazy things. And I'd love to tell you that we have a silver bullet that'll kill the infection for us, but we don't. Although there is a light, there's the theranostatic particle, or as it's fully called, the fantastic multifunctional composite nanoparticle. And surely anything that has the term fantastic in its title must be good. And the theranostatic particle is a multi-layered composite particle of a calcium core polymer coating between which antibiotics are layered. And theoretically, at least, the theranostatic particle is fantastic because it can prevent, monitor, and diagnose the onset of infection and give a targeted release of antibiotics when it's needed, when the bugs are there. What about bone cement? We come full circle. A group of my colleagues in Cardiff have looked at liposomal drug delivery. So we add nano-liposomes to the bone cement, and that doubles the antibiotic release and prolongs the release of antibiotics way beyond 30 days without altering the structure and integrity of the cement. So there is, if you like, cement fighting back. Although treating infection can be difficult, I think we can have the best of both worlds if we think about local antibiotic delivery. If you want to put in a cemented implant, you've got nanoliposomes to increase the antibiotic elution. If you want to use uncemented implants, you've got hydroxyapatite coated with antibiotics, we've got nanotechnology, and we've got fantastic molecules that will help us. Thank you.